Thank you. The mic is up. It was stated earlier that this is really messy, and it is really messy, but the pre-ACA environment was really messy too. And like the president said, it gives us a chance to make our broken health system better. We're in a much better place with the ACA in wrestling with the issue that we're talking about today than in the environment before that, which was largely dictated by categorical systems, scarcity of resources, negative incentives to share because that meant draw on your resources. So there's a lot different today. There is expanded coverage in those states that have chosen it. There's an substantially expanded benefit because of the 10 essential health benefits and federal parity rules and state innovations and states taking advantage of that. But I think the most important thing that I can say in thinking about what this means for the justice-involved population is that it is more money, but don't think in terms of more. You have to think in terms of different. You can't think of new money for old systems, okay? They're really different systems that are being employed here. So the states that are engaging in Medicaid expansion are predominantly in doing it through a mechanism of managed care. And that brings a certain set of delivery system changes that are different than the fee-for-service model. And for those of you well-versed in healthcare, this is like, why are you bringing me back into Managed Care 101? But it's important for us to level set here that managed care means organized delivery, and it means capitation payments. It means a set amount of money. Okay, there's not an unlimited amount of money. There's a set amount of money for a defined set of services for a defined set of people over an amount of time, and there are entities called managed care entities that are responsible to carry out what are called risk-bearing activities, health insurance organizations. Those organizations live or die on data rules. There's a whole set of rules that govern the data, and literally data rules. It rules what managed care organizations do. They are intensive data organizations from the very start of an eligibility file. I promised Steve on a pre-call I wouldn't talk about 834 files and 835 files and things like that, but that is very important in managed care world, is data files, literally files of members and encounters and demographic information and use history and the exchange of that information within a defined network. So I'm raising issues that if we were in the old world, that there's not an incentive to do any of that, but that's a dictum now in the managed care environment. It's really, really critical to understand that, because that is a major motivation. That's the basic architecture of managed care are these data rules, the set amount of money, defined population, and an organized delivery system. I'm going to touch on that in a moment. We're a publicly owned health plan that has 1 million members in it, actually more than 1 million, 1.3 million members, 13% of the Los Angeles County populations in our health plan. We have to use a lot of the rules that our commercial competitors use, okay? So the bottom line is really important to health plans. So this data is not just to document that people get service and so forth for regulatory purposes and are trying to achieve good outcomes. It literally means something to the bottom line, to companies. And so proprietary interests dominate the managed care industry, and you need to be aware of that in those motivations when you're engaging in discussions around this. We have to, at LA Care, have to employ similar types of tactics. We have an internal saying, which is no margin, no mission. If we don't make money, we don't have access to a tax base, we don't have a Wall Street investor community behind LA Care, so if we don't create a margin, we don't survive, okay? So that doesn't mean giving everybody everything. That's an important concept here. So we're gonna have a phenomena, and we have a phenomena of pent-up demand in this newly expanded population. We have a phenomena, certainly within the justice-involved population, of delayed or denied or inadequate care or fragmented care. So there's an impulse to do more. So that really has to be contrasted against this no margin, no mission phenomena. So figuring out the sweet spot for that and figuring out the changes in the delivery system are very important. This is why I'm saying you can't just think about more money for the old structures. They're really different structures. Health plans control a provider network. They determine who is the bona fide provider, who is the credential. They decide what those providers are, whom they are, often with state rules and other types of things. They determine the assignment of the member to the provider. So if the person chooses, or they even determines the menu, or if the person doesn't choose what the assignment will be. Very much like us who are in managed care models in our own health insurance. There's a number of plan functions that need to be understood. We review utilization for higher level services. Sometimes there's active review, sometimes there's things called automatic authorizations or prior standing authorizations. That's for diagnostic services or things that are more expensive. So we make sure that there's proper clinical basis. So Dr. Patel talked about that. There is a variance between what the managed care standard of care is and what the practicing community physician in a safety net clinic might be. Okay, there could be, and it could be a substantial variance between what that is, and we have disputes about that, and there are ways to reconcile it. Timeliness in managed care organizations is what we are primarily regulated. All state regulatory structures look at timeliness to care, timeliness to appointment, timeliness to specialty, timeliness to follow-up, timeliness on rights and appeals. So that's an example of activities that don't exist in the old world. They don't exist in the categorical world. If someone's denied service at a community health center, to whom do they complain? Do they have legal rights to get service? No, that doesn't exist. In managed care, it does. There are established grievance and appeals. There are time windows. There are higher level reviews. There are external reviews for appropriateness of care and timeliness of care. Those are some positive things that operate in that triple aim triangle. There is an intensive set of metrics. They are not standardized across the nation, but there are an intensive set of metrics that are on managed care organizations, particularly in California. There are HEDIS and CAPS. CAPS are assessments of the customer experience, not just the member experience, but also the physician experience as well. We get rated on that. That very important. That's a very important survival technique, as I'll touch on in a moment. And then those are requirements that the state Medicaid agency puts on the managed care plan. For instance, in California, many states do that. They have different rosters of things that are measured and different things that are weighted. Some things are valued more than other things. And then some plans like us, we adopt industry standards like NCQA standards that all apply. That determines who we choose in our networks and what types of capabilities can a provider even provide us with the data and the customer experience and the capabilities to meet these standards. That's an important objective. The consequence of the metrics in California affects our bottom line. The worse we score, the poorer we do in assignment of lives. So we're incentivized from the state to have high quality and high outcomes because when we get better market share. Okay, it's a reinforcing activity. Again, an example of a set of new world activities that you can't really try to, or a set of old. You can't really take the old world to try to insert that into this new environment. There is a difficult phenomena in managed care plans that I think is also operating in the justice in the corrections industry, and it will be I think one of the major challenges in breaking through on this justice-involved population is that just like the jail has a tendency to homogenize and routinize, the health plan wants to homogenize and routinize the members. We want to aggregate as many members on a common pathway as possible. We want to standardize as much as possible. Their exceptions cost money. Their exceptions create systems. Exceptions create variances, more difficult to deal with there. So what we have in in managed care is this great tool, which is we have enormous amount of flexibility. Managed care plans have enormous types of payment flexibilities, of types of mechanisms, but it also has a very rigorous scoreboard that it has to operate on. So that tool really is aligned to what is this scoreboard, and we have this capped environment in terms of financial resources. Most of the Medicaid expansion rates, to my understanding, I've not seen data on this, although from my just asking around, are set relatively high, and that's very positive. But you also have to recognize most of the pre-expansion rates are set very low there because of the FMAP relationship, so the states have to kick in money for this. So it's very difficult for us. We need to think about how do we garner the opportunity of what the ACA expansions are, and how do we build that into the new delivery system that's necessary. In Los Angeles, and this really is a theme from the prior panels, we have to have local planning. Local planning is the key ingredient. I don't know whether the unified model in Vermont and Rhode Island really is applicable in California, but there may be pieces of what's going on there that are applicable, and we have to wire together in Los Angeles. We're going to have to go region by region, urban area by urban area, sometimes state level, sometimes local, to figure out how to create these better relationships between justice and health, the justice community. There's a key consideration in those local planning, which is coordination versus integration. And that last word, integration, is a very tall order about actually sharing active information back and forth across these very complicated domains. And in Los Angeles or in California, we have a greater level of complexity because we have mental health and substance abuse carved out there. So we have a coordination burden across those systems and then to relate to other sectors. So we're not looking at integration, we're looking at coordination. How do we get those systems to line up to one another? We've worked very extensively, actually through another initiative of the ACA, the Duals Demonstration Project, on referral pathways. Like literally detailed manner in which someone with severe mental illness gets handled by the county mental health department, how they might repatriate into the managed care behavioral health delivery system and vice versa. And we've detailed that out, and we've taken a lot of that experience, and we're hoping to use that in our expansion. We also, I don't want to demonize the old world, the old categorical world, because there's tremendous capabilities in the categorical system. And those need to be looked at very carefully and adapted to figure out ways in which providers, community health centers, substance abuse providers, behavioral health providers can adapt to the new imperatives of being a managed care provider. And that's where LA Care, we spend a lot of time figuring out how to invest in that. We invest in EHRs, we've invested in e-consult capabilities, we've invested in provider trainings, and so forth. So those are the types of things that we're looking at in Los Angeles, and I'd be happy to take questions.